Okay, so the third section now of this injury examination, we're going to get into the specifics um, of what kind of goes under the special test portion. Now, like I said before, the special test, yes, there are specific special tests, but there's also going to be other evaluative tests that we're going to do um, within that special test section. And one of those is going to be range of motion. We have active, passive, resistive range of motion, and manual muscle testing. All are going to be very important. Some people within their HOPS form, they have a separate section just for range of motion. They'll have a grid um, where they're able to fill in active, passive, resistive, and manual muscle testing, um, or it could fall under special tests. But range of motion can tell you a lot of information. So I'll go into more about range of motion here in a minute. Um, Also under this section are your joint stability tests. Joint stability tests are really going to test the overall stability of the joint. Stress testing is specifically really for ligaments, like a valgus and varus stress test that we use in the knee and in the elbow and in the fingers and in the wrist are all going to be stress tests where you basically pull the joint apart and see if there's any kind of laxity there. Joint play um, is something that we'll do a little bit, but there is basically you're trying to see what is the overall motion in that joint. Is there a lot of mobility or is there limited mobility? It is really important that with all of these tests we perform bilaterally because we don't know what the normal range of motion is. I mean, we have normative data, but what is normal for that person? We want to check the other side to make sure that we know what the normal active and passive, what is the normal strength, what is the normal laxity within these structures. So active range of motion, something again very important. It is the first movement you're going to have the person do. So they're going to we want to assess not only range of motion, but how willing are they to move their body part. So we ask them to perform whatever the motion is, ask them to, in this picture, do full elbow flexion. The examiner is just holding the goniometer. He is not actually pushing, so we ask the person to just flex their elbow as much as possible and hold it there. They do it under their own voluntary muscle contraction. Again, this is evaluated first because it's going to give us their willingness to move, but you would not want to do any kind of range of motion if anything is contraindicated, which would mean you don't want to do it. And a fracture or dislocation would contraindicate range of motion. So you would not want to assess range of motion if you suspect a fracture or dislocation. When we assess range of motion, yes, we're trying to assess their willingness to move, but we're also going to use range of motion, both active and passive, to try to figure out what type of structure is involved. So when we do active range of motion, we're able to determine if there's any kind of damage to contractile tissue. And contractile tissue would be muscle tissue. So we're able to assess if I ask that person to do elbow flexion and they were not able to produce full range of motion in their elbow, then maybe we're thinking that there might be some elbow flexor muscle problems. Because we're also moving against gravity, there is some certain amount of muscle strength going to be involved, as well as coordination in order to do those activities. So when you have them do active, again, it's the first thing you're going to do. You're looking for overall ease of movement. How did that movement look? Did it seem easy? Was there any kind of compensation? Was there somewhere in that full range of motion where they had a lot of pain? Maybe not so much in the beginning or in the end, but the middle part really, really hurt. So you're going to want to assess all that. So range of motion, I feel like people skip it all the time, but it can give you a lot of information. Passive range of motion is going to be when the clinician actually moves the body part through the range of motion. So with active, the subject, the patient, moves the body part. With passive, the clinician moves the body part. And this is going to be it's going to give you a lot of information. It's another really important aspect where you're able to identify how much range of motion they have. The person is totally relaxed, so they are not actually contracting the body part. So passive range of motion really isn't about muscle pain. It tends to be more about non-contractile tissues. What is the available range of motion for that body part? Because they're relaxed, their muscles are not contracting, so usually when you move through and you have pain with passive range of motion, it is generally not a result of muscle problems. It's usually a result of some sort of non-contractile tissue around the joint. Things like ligaments or capsules, we call those non-contractile or inert tissues. They're primarily made of collagen and they're not muscle tissue. They're non-contractile, they're just a certain length. They don't contract, they don't get shorter, they don't get longer, they just are. So active range of motion is all about assessing contractile tissue. Passive range of motion is looking at movement patterns, total range of motion, and looking at that non-contractile tissue. In general, for passive range of motion, you always want to apply overpressure. So the examiner moves the person through the entire range of motion, and then when they get to the very end, they want to apply even more pressure to see what is the end feel. How does it feel at the end range of motion? Once they achieve that, what do they see? Overall here, we have passive range of motion is going to have a greater total range of motion than active. And this should be something that seems fairly obvious. If I asked you to stand up and bring your foot all the way to your butt actively. So you don't get to use your hands, you just have to bring your foot to your butt. You are not going to be able to touch your butt. You're not going to even make it there. It's not because you don't have the proper range of motion, but really that strength, you don't have the strength at the end range to reach that far. If we did it passively, you could pull your foot and it would actually reach your rear end. So we know that passive range of motion in a healthy person, passive range of motion is going to be greater overall than active range of motion. So that's in a regular person. When we start to have problems here where passive range of motion is actually greater than active, that's when we think there's going to be, so when this person, so what I just mentioned before, that was average. Regular person is going to have passive, is going to be larger than active. When someone comes in and they complain of pain and their passive is greater than active, then we think some sort of muscle problem could be involved. If they're having problems with active range of motion, and there is a big difference compared to normal. So if it looks about the same as the other side, then it's not that big of a deal. But if we have some severe deficiency and passive is much greater than active, and it's not doesn't look normal, it's because we think that there is some muscle weakness involved. If our passive and our active are the same and they're both deficient, then we think there's going to be some sort of problem with the non-contractile tissues around the joint. So we think some sort of capsular adhesion, and what that means is really just a shortening of the capsule around each joint. It could be because of a ligament sprain, overall joint tightness. Those are all things that when passive is the same as active and both are smaller than the other side, that's what we're thinking. So again, let me say it one more time. In a regular person, passive range of motion is going to be greater than active range of motion. In someone who comes in and is complaining of pain, and we find that the passive is much greater than the active, where active is actually very deficient compared to the other side, then we're going to think that a muscle problem is there. Because passively, they can do the motion. We can do the motion to them, but actively, they cannot. If we come in and the person's complaining of pain and they have limited active and passive range of motion, so both of them are deficient, then we're going to suspect not so much muscle problems, but more the non-contractile problems. Manual muscle testing and resistive range of motion. These two terms are oftentimes used interchangeably, but they are technically different things. Manual muscle testing is the whole purpose is to assess strength by relatively isolating a muscle. So the goal is to perform just a break test. That's all we're using the test is, and we're trying to specifically isolate one muscle or muscle group. Um, in comparison, resistive range of motion is assessing the strength throughout the entire range of motion. So they are two different things. Um, Manual muscle tests is supposed to isolate one muscle or muscle group, and we only perform a break test. Then we use that break test to grade it on the 0 to 5 scale. Resistive range of motion assesses strength throughout the entire range of motion. So if I was testing for manual muscle testing, I would say I would like to assess the strength of the bicep brachii, and I would do a break test in order to isolate the bicep brachii. If I was looking at the same kind of idea but resistive range of motion, instead of saying the bicep brachii, I would test entire elbow flexion. And when I test elbow flexion, I'm going to test it concentrically, eccentrically, and with a break test. I am a fan, personally, of resistive range of motion. I think you can get a very good test, and really, when you do concentric and you do eccentric and you do the break test, you're testing that muscle in all ways. Now, it's very difficult to explain without showing you what I'm talking about when I say concentric, eccentric, and a break test, so we will get into that later. Um, but concentric is the actual shortening. So in this case, if this foot started down here, the guy would resist here as the patient actively contracted his hamstring and pulled his foot toward his butt. That's a concentric contraction for the hamstrings. The hamstrings are contracting, they're shortening as he moves his foot up. Eccentrically, in this case, the patient is still contracting their hamstring, but the examiner is pulling down, and the patient is allowing their leg to go down at a very slow rate. So the hamstring is actually slowly lowering the leg down, and that's eccentric. And then when you do a break test, you come back to mid-range, and you ask the patient to hold it at that one angle while you try to break them from that range. So again, resistive range of motion does concentric, eccentric, and break test, where manual muscle testing is trying to isolate one muscle and you only perform a break test. For all of these, both manual muscle testing and resistive range of motion and a passive range of motion, you always want to have one hand proximal to the joint you're testing and one hand distal to the joint you're testing. So you need to have one hand on both sides so that you're able to stabilize. And then after each one, you grade it accordingly. And here is our grading scale. This is for break tests. So when you do your break test for manual muscle test or resistive range of motion, you're going to grade them on a 0 to 5 scale. You definitely need to know this scale. A 0 out of 5, you're going to grade it if there is absolutely no contraction felt. This is worst case scenario. There is probably one of two things is going on. There is either no longer the muscle is no longer attached to the bone, so you have some sort of avulsion and the muscle is not attached, or there's a complete disruption of neurological input and there is no longer a nerve connected to that muscle, so it's not going to fire it. So there is no contraction felt, 0 out of 5. The 1 out of 5 is the patient can produce a movement. You can actually produce no movement, but you can actually feel a contraction. So they contract their muscle, you can feel it twitch, but it's not strong enough to actually produce any kind of movement. A 2 out of 5 is where the patient is able to move a body part through a gravity eliminated position. So full range of motion, but not strong enough to move it against gravity. So if you were sitting at your desk and you tried to produce shoulder horizontal abduction, and you go along your desk, that is in a gravity eliminated position. You are not going against gravity. So if you could do that, then you would be at least a 2 out of 5. A 3 out of 5 is when you can produce full range of motion against gravity. So you are able to, let's say we'll do shoulder flexion, where you're standing up and you bring your shoulder all the way up into shoulder flexion, and you're able to do that, but you're not able to do it with any kind of resistance. So you can go against gravity, but nothing more than gravity. That would be a 3 out of 5. And then your 4 out of 5 is kind of your largest area. Sometimes people use a 4 plus and a 4 minus scale when it comes to um, grading out of the 4, because it is pretty large. Um, the patient is able to go through full range of motion against moderate pressure. So that's why it's a 4 plus 4 minus, because the moderate pressure is a very large term. Um, you know, a 5 out of 5 is when the clinician is not able to break the patient. And we say break, we say, okay, hold your joint right here. I'm going to pull as hard as I can. Don't let me pull it apart. If if you break them, then you move into the 4 section. But sometimes you barely break the person, so it could be like a 4 plus. Sometimes they're not able to produce a ton of resistance. That'd be more of a 4 minus. So your 4 scale is the one scale where you do have some plus or minuses involved. The rest of them are pretty much, they stay as they are. Joint stability tests. We talked about these before. We're trying to figure out how stable the joint actually is. These joint stability tests are all about non-contractile tissue. So we're looking at primarily ligaments and overall joint capsule. And if you guys remember from anatomy, I keep saying this, hopefully you understand, that with a joint capsule, joint capsules are just connective tissue that surround the entire joint. A lot of just reinforcement for that joint, not necessarily individual ligaments, but just support around those joints. Stress testing versus joint play, two different things. Stress testing, you're trying to figure out how much movement there is in the joint, how much laxity do you have before you reach the end point. Joint play is a little bit different, where you place different kind of forces. A lot of times you apply traction, where you pull the joint apart and you do some gliding, you do some movements that you cannot occur naturally. Joint play includes movements that you cannot do anatomically. For example, something like this. You cannot do this without external force. It's not a true anatomical movement, but with external force, then you are able to produce that movement. So stress testing is really looking for overall laxity and what the endpoint feels like. Joint play is doing different things to that joint that are gliding, sliding, distracting, to see how much movement there is within the joint as well. Some terms, we have hypermobile. There's more than normal laxity within the joint. Hypomobile is less than normal laxity within the joint. The terms laxity and instability are somewhat interchangeable, or sometimes they're actually used interchangeably, but they're not necessarily the same thing. Laxity is a clinical sign, and if you remember what sign means, that's an objective, measurable type of thing. So a clinical sign of the amount of give within the joint. This is identified by stress testing. So we're able to actually assess, and if we could, objectively measure the amount of laxity. Some people are more lax than others. Laxity in and of itself is not a problem. It's not necessarily going to link you to any kind of injury. So if you compare laxity, which is your sign, to instability, which is more of a symptom, people will complain that they feel unstable. They feel like it's going to give way, where they can't handle the amount of stress. That's going to be a symptom. The person is complaining of this. So instability and laxity are two separate things. Laxity is not necessarily linked to injury. Instability is a person's perception of the integrity of the joint. How do they actually feel? So someone who is lax could also have some instability. For example, lax individuals just have more range of motion, but say that lax individual then dislocated their shoulder. So then it was reduced, and now their person is still lax, but now their shoulder is also unstable. So they have both. So laxity by itself, not really a problem, but laxity could possibly lead to injury if other forces are involved, and now that structure is now unstable. When it comes to stress tests, we want to grade these on a 1 to 3 scale, just like how we grade the injuries. So basically a grade 1, when we do special tests, when we do stress tests, we try to grade them if possible. So for these stress tests, we use a 1, 2, 3. A 1 is your slight stretching, little pain, little tearing, possibly some ecchymosis, possibly a little bit of swelling, but overall that the endpoint when you actually feel that there is a normal endpoint. So you do a stress test, you test the ligament, you feel a normal endpoint, but it causes pain. That is your traditional grade 1. A grade 2, you do the stress test and you feel an endpoint, but it's kind of soft. You're not, you don't really feel it all of a sudden kick in and stop you. So with this one, the grade 2, there's partial tearing of the fibers, increased movement. The joint could actually open up, and you can actually sometimes see it. More fibers are torn, more pain, more swelling, more dysfunction in your or in your grade 2. In the grade 3, that ligament is completely ruptured. There is no longer anything stopping you. So when you do that special test or that stress test, if you kept on going, you could just keep on going because there is nothing to slow you down, because all the structures are completely torn. Where here, there is still some of the fibers left to hold that joint in place. Down here, there is nothing left to hold it in place. So like I said, for joint play involves movements that are not able to be done anatomically. So in order for us to do like flexion and extension, there's a combination of things that include rolling, spinning, gliding that allow us to perform our total range of motion. But individually, we can't really control any of these. When we are looking for joint play, like I said, a lot of times this involves traction, where you pull the joint apart and then you can kind of move it up and down, side to side. In order to do that correctly and actually assess joint play, the person has to be relaxed and the joint has to be in a loose packed position. So we want them as mobile as possible. We don't want them contracting their muscles and resisting what we're going to do. Then you just, whatever the joint is, you're going to glide it and distract it and just, again, see how much movement they actually have. Make sure that we always compare bilaterally so that we can tell if it's specific to the joint or is this just how the person is. And then your special tests, these are, again, grouped in under the joint play tests and under the stress tests. They are specific procedures in order used to identify injuries to specific structures, where stress tests are used to stress pretty much any ligament. A special test is used for one specific structure and usually has a fancy name. It's a special test when it has a special name. So, like McMurray's test for the knee, like I mentioned before, is specifically for the meniscus. There's going to be a ton of shoulder tests that we're going to get into that all have fancy names because someone invented them for one specific structure and they got to name it. So they are unique to a specific structure. They are usually rated as positive or negative, where a stress test will have a grade of 1, 2, or 3. A special test will have a grade of positive or negative. But just like with the other tests, you want to check side to side. Your neurological screening can also fall underneath special tests or evaluative tests. We'll get into upper and lower quarter screens, specifically your upper quarter screen because it's upper extremity. But we use this to try to figure out if there's anything neurologically going on in the upper extremity. The upper quarter screen is going to involve sensation, motor function, and deep tendon reflex. And that is going to be dermatomes, myotomes, and deep tendon reflex. So if once we test these things, we're really trying to able to figure out, is there any kind of neurological problem involved. If we ask the question way back in the history, do you feel any numbness, tingling, sharp shooting pain, and they say no, then there really is no specific need for us to do an upper quarter screen. But if they answer yes to that question, then you are going to have to do your upper quarter screen. So like I said, dermatomes, myotomes, deep tendon reflex. Your dermatome is defined as an area of skin innervated by a single spinal nerve root. There are a bunch of different types of dermatome maps. I specifically like this one because this is what I was taught. But they're going to vary a little bit depending on what you're looking at. But really the whole point is to assess each of these individual nerve roots and see if they have any kind of deficiency within those nerve roots. You have to perform bilaterally because how are we supposed to know if there's decreased sensation if we don't test both sides? And there are also different ways to test each dermatome. The most common is the light touch discrimination, where you just kind of run your fingers through each area on both arms at the same time to see if there's any kind of difference in how that feels. If you have more time and the right tools, you can do sharp and dull discrimination, where you can get like a brush and a pin, and you can actually say, does this feel sharp? Does this feel dull? Is this soft, or sharp? You're able to differentiate how they feel. So not only can they feel, but are they feeling the correct thing? And then there is 2-point discrimination, and that's what this thing here is. Basically on each side, there are 2 pins that are a specific distance apart, and we keep poking them until they can say, do you feel 1 pin? You guys might have done this in the science class back in grade school. But the more sensitive you are, the longer you can feel 2 individual pins versus having the sensation of just feeling 1. The motor testing part is called the myotome. This is a muscle or muscle group innervated by a single nerve root. So they've figured out what muscles are innervated by what nerves. So if we can test that correctly, we can find out what actions are weak and where is that coming from. So we just use muscle testing, basically break tests, to try to figure out which, if any of these muscles are actually weak. So there's going to be specific muscles that we'll talk about when we actually cover the upper screen. But it is important to figure out if there is weakness from the screen, you need to test another muscle in the same area so that we know it's from the same nerve root instead of just thinking it's from a muscle pathology. And then the last part is the deep tendon reflex. The DTR is going to give us information about the overall integrity of the entire spinal nerve root, kind of the entire circuit. So in order for us to have a reflex, we have to complete the circuit. So we have muscle spindles in the muscle. It's responsible for detecting stretch. It's going to send the signal to the spinal cord. The spinal cord is then going to send a response that says contract. So reflexes are going to end up giving you making sure that you know the entire picture, entire loop is intact. This maneuver down here is called the Gendrastic maneuver. Some kinds can be used for the lower extremity, obviously, to get them to relax and not to focus on the fact that you are doing a reflex testing. There is a grading scale for reflexes. It's different than what you would think it would be. 0 is no reflex elicited. Hyperreflexia is a +3. Normal is a 2 plus. So a 2 is normal, 3 and 4 are very hyper, 1 is hypo. So 0 to 4 scale with 2 being normal. And then the last thing is the vascular screening. Again, you are not going to always do this. Really, only if you feel there is either profuse bleeding, there's a fracture or dislocation, if you put on some sort of bandage that you think is too tight, or the injury that you think they have is linked to decreased circulation. But the primary things we do here are capillary refill, where you all you do is pinch the fingernail and then you wait to see if the blood returns. So when you pinch it, the nail bed gets white, and you want to see how long it takes for the nail bed to go back to the normal color. Not 100% ideal, but it does give you an idea if there is blood in the area, because when you push down on it, you squeeze all the blood out. You want to see it when it comes back. A little bit more specific, specifically in the upper extremity, we have our brachial, radial, and ulnar arteries that run through. The radial is the most common, because you can feel that one on the anterior lateral part of your wrist. You can, if you're pretty good, you can feel a little slightly on the ulnar, which is on the anterior medial side of your wrist, and then your brachial artery is going to be on the kind of anterior, more medial side of your upper arm. More difficult to actually palpate, especially if there's more tissue in the way. So if someone does experience a shoulder or a humerus or a elbow or radial ulnar fracture, you are going to want to assess the distal pulses. Just like in the legs, if there's anything going on in the legs, you want to assess the pulse that's directly distal to what you're dealing with. More systemically, full body wise, the carotid artery is responsible for systemic circulation. So it's not going to tell you if the blood is flowing all the way down to the fingers, but it will tell you that the heart is beating and blood is flowing. So depending on what you have going on, if you suspect any kind of fracture or dislocation, you want to assess an upper extremity pulse so that you know that blood is still getting to the distal extremities. If blood is not getting down to the extremities, then you have a larger problem than just that initial injury. All right, so that's the end of the injury examination chapter.